So I will be talking about the different types of plaque disruption as seen by OCT. I've always been interested in that topic, especially when I was a resident. I always wanted to know what's the difference between plaque rupture and plaque erosion. People use those terms, and I hope I will be able to show you the difference in this presentation, okay? So plaque rupture, which is the more common process in the coronary, that's probably 70% of acute coronary syndrome. This is erosion is probably 25%. So plaque rupture is a ruptured thin fibrous cap in continuity with a necrotic or lipid core. But the key idea is that there is a ruptured thin fibrous cap. Plaque erosion, on the other hand, there is a thrombus formation over an intact fibrous cap. There is no plaque rupture, no cap rupture. In fact, the fibrous cap is often a thick fibrous cap. So we have a thrombus on top of a thick fibrous cap. And that thick fibrous cap is rich in smooth muscle cells. So no cap rupture and plaque erosion, just thrombus over a fibrous intima most often. Plaque rupture, there is a ruptured thin fibrous cap. And I'll show examples. Plaque erosion compared to plaque rupture, it occurs on average on less stenotic lesions with less heavy atherosclerosis burden and less plaque burden and less positive remodeling. 30% of MIs are plaque erosion, primarily in patients less than 50, primarily women. So you have an MI in a 40-year-old smoker, it's relatively more so erosion than rupture. It may be 50-50 in this age range. This is a pathology image of plaque erosion. So we have here a nice fibrous intima that is not ruptured, and on top of it, you have a thrombus. Now, even though I say it's a thrombus on top of a fibrous cap, you could have lipid, and you frequently in plaque erosion have lipid, except that lipid is not exposed to the lumen and is not in continuity with the thrombus. That's another example. In this case, you have a really thick fibrous cap and smooth muscle cells and thrombus on top of them, no rupture. And there is a necrotic core or lipid core, again, not in continuity with the thrombus. That's the difference between erosion and plaque rupture. Plaque rupture, this will be thinner, much thinner, and there will be defect communicating that part with the thrombus. And those are examples. Those are some examples. This is a plaque rupture. So there is a cap. You see, this is a thin cap that has ruptured, and there is a cavity behind it. Okay. And interesting, that thin cap, notice always your eyes, let them catch lipid. There is a heavy amount of lipid. You see that dark, loose edges structure here? This is lipid. This is lipid here too. Okay. This is, by the way, don't think this is lipid. It could be, but there is actually a wire artifact, so I cannot tell. But there is lipid here, and there is a lot of lipid there with a plaque rupture. On the other hand, this is a plaque erosion. Okay. So you see a thrombus overlying an unruptured cap, fibrous cap, unruptured. It is thin in places, but there is no discontinuity. It is a red thrombus. It creates shadowing behind it and attenuation, but there is no interruption of that cap that I see. So it's a thrombus on top of a fibrous intima. Okay. And again, this, if you measure it, this will be less than 65 micrometer, which is what we call thin cap fibroatheroma, TCFA, which has rupture. Those are some other examples. Thin cap that is ruptured, there is discontinuity with here white thrombus, doesn't attenuate the light, and the cavity. This is another, this is an example here of erosion, plaque erosion. So you see thrombus overlying an unruptured, non-ruptured cap. Okay. And in this image here, you probably see some probably see also some in this thin cap rupture with plaque rupture. You can see also some lipid. They often go hand in hand. You can see lipid in plaque erosion as well, as I showed in that pathology slide. So actually, frequently you see deep lipid in plaque erosion. It's just not in continuity with the thrombus. There is a good cap, some often thick cap separating them. Okay. As far as the mechanism, it's not well clear. There are, the mechanism of plaque erosion just quickly. One is that plaque erosion, you lose, even though your cap looks great, you actually lose endothelium on it. And that's why you get thrombus formation. But you're not going to see endothelium by even OCT, because endothelium is much less than 10 micrometers. It's like 1 micrometer. So plaque erosion, you don't have a rupture of a cap, but you lose the endothelium from the surface. And it's related to several risk factors, such as smoking. Another thing with plaque erosion is that there is theories that those may be hypercoagulable patients who get thrombus formation because of hypercoagulability on top of loss of endothelium on the surface of the fibrous intima. Okay. This is another illustration here. This is another illustration of what I just described. So this is plaque rupture. Okay, this is not erosion, plaque rupture. So look at the cap here, and there is interruption with a dark substance. This is here a lipid core. This is lipid, and that lipid is bulging, probably with a small, maybe with a small pieces of white thrombus. So this is here plaque rupture. This is another case of plaque rupture. Okay, again, fibrous intima, kind of thin, and there is interruption by a different looking substance that is darker. This is here a thrombus formation. Okay, thrombus formation with cap rupture. Probably there is a lipid core here bulging along with the thrombus. Those are also more OCT images. So in that particular understanding of a plaque disruption is really useful in patient with MI in whom you find no obstructive coronaries, what we call MINOCA. Okay. It will be important to define if they have plaque disruption in order to decide whether they need specific CAD therapies. So this is a patient with MINOCA, positive troponin, no obstructive CAD. And this is what OCT showed in this patient. So one, you see heavy lipid core. Okay. This again, dark, low intensity, loose edges. So heavy lipid core here. Then you see here afterward, this is a plaque rupture with thrombus formation. So you see, look at the cap, it's thin, and you see it here, it's thin cap that all of a sudden is broken, and you get thrombus formation. And actually, you probably get a bulging of some of that lipid with pieces of thrombus on top of it. Okay. So this is another image. This is more clear. You have a clear-cut interruption of that thin cap. It's broken, and you have thrombus bulging through it. Thrombus and some of the lipid itself, the lipid core bulging through it. So this is plaque rupture in a patient with MINOCA. I do want to insist, though, as I mentioned in a prior lecture, MINOCA, if you find a plaque rupture of plaque erosion, that's great. To tell you that you need to treat this patient with dual antiplatelet therapy as medical management, aggressive statin, and aggressive risk factor control. But just seeing plaque rupture and erosion does not mean you should stent that patient. There is no data, at least, for it. And actually, there is the MINOCA AHA scientific statement from 2019, agree with my perspective, is that we don't routinely stent patients based on just plaque rupture or erosion. The only indication to stent those patients is if you have residual stenosis over 50%, as it has been in all of the initial invasive strategy of non-STEMI, or if your MLA is less than 4 millimeters square, as this cutoff has been used to decide about stenting with IVUS in general, particularly less than 3 millimeters square. But you don't stent just because you see this. You have to have stenosis compared to the reference over reference distal or proximal reference over 50% or MLA less than 4. Okay, but that will help you decide what the diagnosis is and how to treat it medically. Those patients do well with dual antiplatelet therapy, including Brilinta, which is an appropriate medical therapy in non-stented patients based on the Plato trial. So anyway, this is another example here. Again, MINOCA. This patient had MI with non-obstructed coronary artery. So they did OCT, and this is an interesting find here. So there is no plaque disruption, no plaque rupture. Look at this. There is a nice fibrous intima that is not interrupted anywhere, and I don't see any thrombus overlying it. So there is no plaque rupture, no plaque erosion. But there is this interesting phenomena that Reynolds and colleague describe very well. So you see here a fibrous intima, okay, that all of a sudden has a sharp bend, and beyond that sharp bend, it starts to look different. You see lipid core covered by some fibrous or some heterogeneous type of intima. Whenever you see that, a nice intima with an abrupt sharp bend followed by a lipid core and that is covered, this is an indication of what we call layered plaque, which indicates a recent plaque rupture. And I'll tell you how it happened. So basically, this patient had a heavy lipid plaque that ruptured, and it ruptured here where that acute dark angle is. As with most plaque rupture, the body heals those plaque rupture. And so it will cover it by fibrous intima. The key is that sharp bend and lipid core beyond that bend. It's not very easy to define, but that was actually a common mechanism in MINOCA. The third type of plaque disruption, so I mentioned plaque erosion and plaque rupture. The third type is what we call eruptive calcific or calcified nodule. I described it earlier. So this is a superficial calcium. This is the calcium in this slide, the red and multicolor thing here. So superficial calcium that fractures the cap. This is the cap. The superficial calcium fractures the cap and bulges into the lumen and attracts thrombus. There is often, but not always, a thrombus. This is what we call eruptive calcific nodule. This is an OCT image of it, okay? So you have calcium here. This is a piece of calcium, a well-demarcated dark granular structure. It actually ruptures that cap. Look at that cap, it's interrupted, it ruptures it, and a thrombus is formed, okay? It is a form of plaque rupture from calcium. That's what eruptive calcific nodule. Plaque rupture from a piece of calcium. So it's a malignant type of calcium that leads to thrombus and acute coronary syndrome. This slide summarizes all three processes I described. This is an example here of plaque rupture. Again, thin cap that is ruptured, okay? And you see heavy amount of lipid, even before the ruptured area. You see heavy amount of lipid that, again, loose edge dark structure. You see here the cap rupture with a large cavity, okay? So this is a plaque rupture with heavy lipid core. This is here plaque erosion. Again, uninterrupted cap, thick cap, relatively thick cap, uninterrupted, all of a sudden you see thrombus. You know, you might think the cap is interrupted, but it's really shadowing from a red thrombus. So it's sometimes hard to tell for sure whether, well, it is plaque rupture or not, but it's really very irregular. You know, there is really no disruption. It's really very smooth. That area, that lumen goes very smoothly into the thrombus. So it's really hard to say there is cap rupture in this patient. Unlike, for example, here, it's not as smooth. But again, you know, you could tell, well, is there here, maybe this is plaque erosion too. It's not always easy to tell. Just realize, not always easy to tell. But with time and practice, you'll be able to. So, and this is the third entity, the eruptive calcified nodule. So you see calcium here, that well-demarcated dark substance. And that well-demarcated dark substance suddenly bulges through the lumen and probably forms a pieces of thrombi on top. Those tiny pieces here are probably pieces of thrombi on top. This is the classic image of an eruptive calcific nodule. Okay. I will quickly describe two more entities. So we have 5 types of plaque disruption. I mentioned plaque erosion, plaque rupture, eruptive calcific nodule. Those are the 3 most important ones. There is an entity called lone thrombus, which really very much overlaps with plaque erosion. I think a lot of investigators, lump them together as one entity. So lone thrombus is a thrombus formation on top of a normal intima. An intact arterial wall. Again, it can be similar to plaque erosion. So this is a thrombus on top of very nice fibrous intima that is almost normal. It's not thick. So, and that's what you call lone thrombus. Unlike plaque erosion, there is minimal plaque. So plaque erosion, you do have thick fibrous intima. You frequently have lipid or necrotic core behind the fibrous intima. Lone thrombus, you just don't have much plaque. Not much fibrous intima and not a whole lot of, and not at all any lipid, okay? And not calcium either. So it's just thrombus without much plaque, whereas plaque erosion is thrombus with more plaque, okay? That's kind of, again, you can lump it with a plaque erosion since it's really hard to distinguish that. This is the more important type, the more important last type for me, the 5th type. So this is a patient who had a positive troponin, and you see distally that distal long, smooth, tortuous narrowing. They did OCT here, and you need to recognize that structure. It has 3 features. So this is the lumen, the black, and there is this crescent shape, semi-lunar structure that becomes dark deeply, well demarcated. Anybody can knows what this is? The angiogram can help you too.
SCAD.
Excellent, excellent. This is a SCAD, okay? Spontaneous coronary artery dissection. So this is intramural hematoma from SCAD, okay? You need to recognize that structure. It has those 3 features. When you have those 3 features, you should be diagnosing SCAD. It's not always easy. You don't always have those, but you should seek those to make the diagnosis. So 1, it's semi-lunar or crescentic, but it can be sometimes fully circumferential. 2, it's dark deeply. 3, it's well demarcated by the media, and it pushes the true lumen. For example, this is in the same patient and at a different part of the scanning, of the longitudinal scanning. And you see here, not just the hematoma, you see you see the intimal tear. Now, if you only see this image in isolation, for me, I would think, okay, well, this is cap rupture in a patient with heavy lipid core. It can totally look like this. That's why it's sometimes hard to distinguish, in my opinion, SCAD from just a ruptured plaque. You should seek at some point in your longitudinal scanning, you should seek that characteristic image. Again, like a banana image, well demarcated, deep inside it, it's dark, dark speckled. You got me? This to me is harder to delineate. You should seek some image like this. Those are other examples of spontaneous coronary artery dissection. Again, this is the classic angiographic morphology, distal, long, smooth, tortuous narrowing. So this is intramural hematoma. Again, kind of that crescentic. Here it's more circumferential, dark, deeply, well demarcated. Intramural hematoma, again, dark, deeply, well demarcated. This is really severe SCAD, circumferential. So SCAD can look like lipid plaque inconsistency, as I explained, except it's well demarcated, semi-lunar or circumferential shape, and dark speckles deeply. So another example of SCAD, again, this one here, it has that crescentic, large, in this case, crescentic, almost circumferential SCAD. It's mostly here crescentic. Here it becomes circumferential. 4 months later, with just conservative management, SCAD has here, that intramural hematoma disappeared just with conservative management. That's why we only stent and intervene on SCAD if it is causing ongoing STEMI or ongoing severe ischemia with ST changes or ongoing severe angina or hemodynamic compromise or impaired flow, less than TME2 flow. Otherwise, we try to treat those conservatively. This is another example of SCAD, false lumen. They call it false lumen here, that's fine. It's a false lumen, again, crescentic, well demarcated. And you see on the longitudinal display a cap, the intimal tear or cap tear, okay? Here again, it's crescentic. Unfortunately, you're interrupted by the wire shadow, but this is a crescentic here, well demarcated. That image in isolation might be difficult to analyze. You have to do the longitudinal display and look at more images to see something more characteristic like this. This is another example. Again, here, circumferential SCAD, well demarcated, circumferential intramural hematoma. Here, the authors consider that as a SCAD, but I'll tell you, if I look at this myself, it looks to me like a thrombus, particularly probably red thrombus with shadowing behind it, overlying an intact arterial wall, intact intima. So I would call this plaque erosion myself. Again, here the wire shadowing confuses the picture, and the plaque here would seem to me lipid rich. So I would call it thrombus, plaque erosion on top of lipid rich plaque. That's how I would call it. But that's why you need to have experience in those. And in fact, what this is intramural hematoma, this area, that crescentic area, this is intramural hematoma with a thrombus formation on top of it, okay? And that explains to you why with the SCAD, we use some degree of antiplatelet therapy. We definitely use aspirin. Plavix is controversial, but probably Plavix for a month is commonly used, according to most investigations I looked at, without clear-cut data, but most registries have used Plavix for at least a month. Okay. I want to show you SCAD on IVUS. Here's the thing: when we have a spontaneous coronary artery dissection, most often we try to make angiographic diagnosis, okay? Because wiring that and doing OCT or IVUS by itself can expose you to a risk. Now, if you choose to do imaging because the diagnosis is not clear, really my preferred imaging for that is IVUS, not OCT, because OCT, like I said, you need to do high contrast injection. And therefore, that high contrast injection can create hydraulic dissection. So even though OCT gives you better images for SCAD and it provides you with a higher likelihood of a diagnosis, unfortunately, OCT is probably more risky in theory. That's why IVUS is the go-to, to me at least, intracoronary imaging for SCAD. Now, that's why you need to recognize the images by IVUS. And this is the classic, this image D is what you need to memorize in terms of SCAD on IVUS. So you see again, like by OCT, that crescentic, well-demarcated structure, that is the intramural hematoma, okay? That is dark, somewhat homogeneous, but relatively dark, not very bright. That's how a SCAD look like. It often tends to be on the darker side because it's blood, okay? Kind of as dark as the lumen. So that's how a crescentic, relatively dark structure, usually homogeneous, well demarcated. In this patient, he has multiple pieces, pockets of intramural hematoma. He had this, had another piece, and another piece. But the giveaway to me is this. Those can be considered, you know, plaque rupture, lipid core plaque, but this is what gives away SCAD to me. Same here, 2 pockets of intramural hematoma. This, on the other hand, is hard for me to tell it's SCAD. This patient here, they consider that SCAD with multiple pockets of intramural hematoma. As you can see, this, those dark pockets. It will be hard for me. To me, that could look like heavy plaque with echolucent area of necrotic core or lipid core. So I would have called this probably more unstable plaque than SCAD. But again, on longitudinal scanning, you will look for area that look like this, that banana well-demarcated structure. And all of the above, so there are those 5 types of plaque disruption, and they are particularly useful to study in MINOCA patient. And those are 2 major landmark studies, 2020 and 2021, that describe the frequency of those 5 findings in MINOCA. Okay, and there was a plaque disruption in over 45% of patients with MINOCA based on those 2 studies. They use a little bit of different terminology, but I tried to unify their terminologies. I will finish with one more thing that I really like here. This is not a plaque disruption, but I do want you to recognize this. So this is an Intima. If you look at, this is somebody who had an MI. They did MI with non-obstructive coronary arteries. They did OCT. And again, that Intima looks fairly normal. Look at the Intima, that bright yellow. It's fibrous Intima, fairly thin, actually. You can even see a media behind it. You see that dark structure behind it. It's really almost a normal vessel. You see media and you see adventitia. Here you see media and you see adventitia. It's really a normal vessel. Intima, media, it's really, you know, almost a normal artery, minimal atherosclerosis. No plaque disruption. But yet they found this wrinkles on the surface of the Intima. Can anybody tell me what this is? If anybody knows what that is, he would be a superstar. This is what you call intimal bump or intimal wrinkles. And as defined by Reynolds, this is very diagnostic of a recent coronary vasospasm. So the artery shrinks during vasospasm, then it relaxes. And like an inflated balloon that you deflated, you're left with some wrinkles. And it was defined in this, they called it intimal bump, and it was diagnostic of spasm. So very interesting finding, I want you to recognize it.